Okay, so here is part 2 of Unit 7 ECG interpretation, I think. There we go. So this is part 2 of your Unit 7 ECG interpretation lecture. I'm going to, again, break it up, so if there is something that's wrong with the lecture, then at least I don't have to re-record the whole thing. So I left off on slide 10, ECG is what? So I'm just going to recap here. So it's a step-by-step process to determine what an ECG rhythm is actually telling you about the patient. So the first step in that step-by-step process is determining the heart rate on the ECG. So generally speaking, your cardiac monitor will tell you what the patient's heart rate is. Just be cautious to confirm that by also checking the patient's pulse. Your cardiac monitor isn't always accurate, so you want to make sure that you're feeling that patient's radial pulse, provided they're alert and oriented and conscious, and making sure that it matches the monitor. And I can explain to you probably better in person what that means if you don't understand what matching the monitor means. But in terms of an ECG strip, there's a couple ways of determining heart rate and regularity. So the first way is to print off a 6-second strip and count the number of QRS complexes in that 6-second strip. So if you have, let's say, 6 complexes within that 6-second strip, and you multiply that by 10, which would give you the number of QRS complexes in 1 minute. So again, 6-second strip multiplied by 10 will give you the number of QRS complexes in 1 minute, which would then give you the heart rate. So if we had 6 QRS complexes in that 6-second strip, you multiply that by 10, we would have a heart rate of 60 beats per minute, 60 QRS complexes per minute. And again, I would caution that you double check that the patient's pulse is matching that. The other way to determine the heart rate based on an ECG is to use this counting method. And I'll demonstrate this in some slides following this, but imagine you have a QRS complex that falls on this line right here. If your next QRS complex were to fall on this line, then your heart rate would be 300. If your first QRS complex is again on this first line, and the next QRS complex doesn't fall until this dark line, then the heart rate would be 150. And so on. And we'll do a little bit of practice in the next slide to demonstrate how that really works. The next thing in the step-by-step process is to determine the PR interval. So again, we talked about the PR interval being less than 0.2 seconds or less than one big box. That's what we're looking for in a healthy heart. So that's important to note. Number 3 is to note that the QRS complex is either narrow or wide. A narrow QRS complex, which is found in a normal functioning heart, is less than 3 little boxes or less than 0.12 seconds. That's what we're looking for. Number 4 is the ratio of P waves to QRS complexes. So remember back to the conductivity of the heart. The P wave represents the atria contracting, and the QRS complex represents the ventricles contracting. So what we want to see is a QRS complex following every single P wave. That way we know that the atria contract and then the ventricles contract, and then the atria contract and then the ventricles contract. This should be rhythmic. In a normally functioning heart, you have a P wave followed by a QRS complex. So that's what we're looking for on the ECG. And then finally, step 5 is the actual interpretation of the ECG. So here's another slide to sort of demonstrate that counting method. So this is the method that I would choose to use. So look at this QRS complex right here that falls on one of those dark lines on the ECG paper. And one of the dark lines, again, denotes one of the big boxes. So this QRS complex falls on this dark line. The next QRS complex doesn't fall until way over here. So let's start counting. That first QRS complex is 0. The next dark line is 300. Next dark line is 150. Next dark line is 100. Then 75. And then 60. Because that QRS complex falls somewhere between 75 and 60 and closer to the 75 mark, I would say that this heart rate on this ECG is probably around 70 beats per minute. So let me pause right there, and I'll let you sort of look at that a little bit more closely and try that on your own. Okay, so let's do that again. So find the QRS complex that falls on a dark line, denoting one of the dark boxes, one of the big boxes, and then count 300, 150, 100, 75, 60, and again, because that QRS complex fell somewhere between the 75 and 60 heart rate mark, a little closer to the 75 one, that I would call that a heart rate of about 70. All right, so here we get to practice a little bit. So have a look at this first one in the top left. That first QRS complex falls on a dark line. Next one would be 300, and the next one would be 150. So the second QRS complex happens to fall on one of those dark lines, so that's an easy one. We'll say that the heart rate of this one is 150. So do the next one on your own here. All right, so that first QRS complex falls on a dark line. So the next one would be 300, 150, 100, 75, 60. So the heart rate of this patient's ECG is 60 beats per minute. Try the third one on your own. So for the third one, we're starting a little bit to the right of a dark line, but that's fine. Let's go 300, 150, 100, 75, 60, 50, 43, 37, 33. So this patient's heart rate is about 33 beats per minute, which is quite bradycardic. Let's do the fourth one here. So the first QRS complex falls on a dark line. The next one would be 300. The one following that would be 150. But the QRS complex occurs before we hit the 150 mark. So if you split the difference between these two lines, between 150 and 300, I would say that this QRS complex falls probably on about the 200 mark. So the heart rate of this patient is about 200. So try this one up here on your own, top right. So from that first QRS complex, we count 300, 150, 100, 75. Difference between 75 and 100, I'd probably call this about 87-ish. So try the next one. So hopefully you're feeling a little bit more comfortable with this by now. If not, stop and do all of these all over again. So start with that first QRS complex, 300, 150, 100, 75, 60, 50. Halfway between 50 and 60, 55. So that heart rate is about 55. Now if we move on to the last one, you'll see that this QRS complex falls about in the middle between these two dark lines. So you could count from the middle of this one to the middle of the next one to the middle of the next one, or because the next QRS complex falls on a dark line, you could count backwards. So I would simply count backwards. Or if you had a longer ECG strip, you could simply start with this QRS complex and start counting towards the right. But because we don't have that, I would go backwards. So 300, 150, 100, 75, 60, 50, 43, 37, and because this QRS complex falls right between 43 and 37, let's call that a heart rate of about 40. So again, this patient is bradycardic. So if you feel like you need a little bit more practice with this one, stop now, rewind, and go back over that again. So we talked about the PR interval. So now, so far, we know how to count the heart rate. We know how to count the rhythm. So next thing we're going to talk about is the PR interval. So we've already talked about this. It represents the time it takes for an impulse to travel from the SA node to the bundle of His. So that incorporates the atria contracting and the time in between. So from the beginning of the P wave to the beginning of the QRS wave, QRS complex. So this represents the atria contracting with the P wave, return to isoelectric line, and then the beginning of the ventricles contracting. Okay, so this is our PR interval. And again, we want this to be less than 0.2 seconds, which is less than one big box. Okay. The other thing we need to look at with our P waves is there a P wave for every QRS complex? So we talked about this earlier. Do the ventricles contract in response to the atria contracting every time? So in a normal heart, that's what we see. We see the atria contract and then we see the ventricles contract. That's what we want to see. We want to see a ratio of 1 to 1. And then the other important thing when looking at the P waves is what do they look like? This is a normal P wave. It is upright. It precedes the QRS complex, and the distance between the beginning of the P wave and the beginning of the QRS complex is less than 0.2 seconds. There is a possibility in a not so perfect heart for that P wave to either be upside down, which would be inverted. It could also be absent, or it could be retrograde. And a retrograde P wave simply means that it comes after the QRS complex. And I'll explain that after. So here, the QRS complex, as we talked about earlier, represents ventricular depolarization. So that's the ventricles contracting. And again, it should be less than 3 small boxes, or less than 0.12 seconds. So if it is less than 0.12 seconds or less than 3 little boxes, it's considered narrow. If it's greater in size than 0.12 seconds, it's considered wide. And a wide QRS complex is associated with some patho issues, some heart problems. Okay, so that's why we're looking for the difference between a narrow QRS complex and a wide QRS complex. So here's a little bit of the how behind recording an ECG. So typically, and you'll notice this hopefully on your cardiac monitors in the lab, that you have 4 wires attached to the cardiac monitor, and each of them indicates where to put the probe, so where to put the actual electrode, the sticky part to the patient. You'll see RA for right arm, LA for left arm, left lower, and right lower. So ideally you have them up near the clavicles of the patient and down near the lower abdomen of the patient on either side. There are some people who put them on the arms, the wrists, and the ankles. That's okay too. Either is fine. I like to put them on the core only because when you start moving the patient, you get them on a stair chair, you get them on the stretcher, the cables tend not to get in the way as much. So why are we looking at ECGs? Think about a patient with who's complaining of chest pain. Why are we interested? Why do we want to see what their heart rate is? Will it determine our treatment plan? So there's an adage out in the field that you'll hear, probably from preceptors or maybe medics working in the lab, that you never treat the monitor. Well, that's sort of half true. So our monitor is a tool that helps guide us in a certain direction. It doesn't replace our own clinical judgment. It goes hand in hand with it. So you need to make sure that you're assessing your patients appropriately, you're asking all the right questions, and then you're using your cardiac monitor and your ECG rhythm to either support your differential diagnosis or to maybe challenge it. And you're going to use the information in your ECG to make certain decisions. And that's what it's there for. It's a tool to use to help your decision-making process. So keep that in mind. And so when do we take these ECGs? There are some patients that you'll determine are too sick to to fiddle around on scene and take an ECG. And that's great. There are some patients that are too sick that you need to load and go. Perhaps this is something you do in the back of the truck instead of on scene. Most often, you'll walk in on scene, and as the attendant, you'll start asking all the right questions, and your partner will have hooked up oxygen, the cardiac monitor, got you a set of vitals, maybe started packaging the stretcher, getting things ready to start moving, and you'll have to look over at the monitor and determine what it is you've got. So a lot of this will happen simultaneously, and we can run through sort of a scenario in class to show you what that would look like. But keep in mind, as the attendant, your partner generally will get that stuff done for you. There are a number of medics who like to apply the cardiac monitor as they're asking questions. It's completely up to the medic and how they like to flow their call. But just keep in mind that some patients are just too sick for an ECG rhythm and you need to get going. And in that case, there's a delay to an ECG rhythm, and that's okay. Maybe it's in the truck, perhaps the patient's VSA, and you just never get to it. And that's okay too. It's just a matter of prioritizing what's important for that patient at that time. And perhaps it's load and go. So we're going to get into some of the basic rhythms here. The basic ECG rhythms we're going to talk about are your sinus rhythms, junctional rhythms, tachycardias, blocks, atrial fibrillation, and atrial flutter. So in most of these slides, I have a number of examples. So a lot of the times I'll go through just a couple of them, but what I'm going to recommend you do is really pause here. So I'm going to explain what to look for these rhythms. Pause and then go over it on your own. Really practice. Force yourself to do this. ECG interpretation can be very difficult if you don't go through the steps. So I would recommend you take your time, you go through every single step, and you practice a lot. I'm sure there are resources out there. There are full ECG practice books, but there's a number of resources online. I've created a Kahoot on this, so hopefully that will help you. Just take your time and go through every single step. So if we look at normal sinus rhythm initiates up in the SA node. So when I talked about what a normal heart does, well, this is what a normal heart looks like. So normal heart is in normal sinus rhythm. So let's look at the P waves. So this is how you start. Your step one, let's look at our P waves and determine our heart rate. So actually, let's do our heart rate first. So if you find a QRS complex in our first strip that falls on a dark line, so here's one here. Let's count 300, 150, 100, 75. So between 75 and 100, I'm going to call this heart rate probably about 85. So the definition of a heart rate for normal sinus is between 60 and 100. So far we've checked that box. Now let's look at our P waves. Do we have a P wave in front of every single QRS complex? So have a look. Determine whether our ratio is 1:1. So make sure you look at them all here. So we're going to focus on the first strip here. I'd recommend you pause and then go through strip 2 and strip 3 on your own. So strip 1, yes, there is a P wave before every single QRS complex. Great. Is our PR interval less than 0.2 seconds, which is equivalent to less than one big box? So let's do the first strip here. So from the beginning of the P wave to the beginning of the QRS complex, yes, that is less than one big box. And now do that for every single P wave to QRS complex. So they are all less than 0.2 seconds. So have a look at my cursor here. I'm measuring the distance between the first positive deflection of the P wave and the beginning of the QRS complex, and they are all less than one big box. Perfect. The other thing to look at our P waves is, do they look normal? Are they upright? Do they precede the QRS complex? And in fact, they do. So next thing to look at is our QRS complex. Is it narrow? Narrow meaning less than 0.12 seconds or less than 3 little boxes. So let's look at that first strip again. So the QRS complex is absolutely less than 0.12 seconds because it's less than 3 little boxes. So make sure you're looking at every single complex here. Perfect. So the QRS complexes are narrow. So again, this is normal sinus rhythm. The other thing to look at is the regularity of the rhythm. Regularity refers to the distance between QRS complexes. So are our QRS complexes happening at the same regular rate? So is the distance between each of these QRS complexes the same? And in this case, yes it is. So for normal sinus rhythm, we have a normal looking P wave before every single QRS complex. Our PR interval is less than 0.2 seconds. Our QRS complex is less than 0.12 seconds. Our heart rate is between 60 and 100, and our rhythm is regular. So again, I can't emphasize this enough, guys. Practice, practice, practice. This is going to take a lot of practice, so put the hours into this. We've focused on the first strip here. Now you focus on the next two. So the next ECG rhythm we're going to look at is sinus arrhythmia. So sinus arrhythmia is very similar to normal sinus rhythm. However, it is not regular. So everything else is the same. So your P waves look normal. There's a P wave before every QRS complex. The PR interval is less than 0.2 seconds. The Q wave is less than 0.12 seconds. The regularity, though, again, is different. So look at the distance between these QRS complexes. They're all different, which means this rhythm is irregular. It is regularly irregular. Okay? Sinus arrhythmia is usually caused by breathing. So as you inhale, you cause increased pressure on the heart, which causes the heart rate to speed up a little bit. And when you exhale and empty the lungs and decrease the pressure on the heart rate will slow down. So that is sinus arrhythmia. Sinus bradycardia is the exact same thing as normal sinus rhythm, however the rate is less than 60. So you'll notice a lot of similarities here. Keep in mind, in order to recognize these, you need to go through every single step. So go through all of your steps here. Don't skip any steps. Don't look at the rhythm as a whole. You'll get caught making a mistake if you do that. Go through all of the steps. Sinus tachycardia, exact same thing as your normal sinus. However, the heart rate is greater than 100. So again, go through every single one of these steps. Really focus on determining where the outlier is in these steps. Now we'll look at supraventricular tachycardia, normally referred to as SVT. So SVT is a rhythm that starts in the atria because you have a narrow QRS complex. So anytime you have a QRS complex that is normal, so that is narrow, meaning less than 0.12 seconds long or less than 3 little boxes in duration. That is a normal QRS complex. It's narrow. A narrow QRS complex is one that originates in the atria. So if the pacemaker cells are coming from the atria, causing the ventricles to contract normally, which means a narrow complex, we consider that a supraventricular tachycardia, meaning the origin of the impulse is supraventricular, above the ventricles. What is above the ventricles? The atria. So the atria are causing contraction of the ventricles in this case because we know that because the QRS complex is narrow. So let's look at identifying this rhythm as a whole. So let's start our steps. What is our rate? Well, let's find this QRS complex falls right on the dark line. So 300, 150. this rate is between 300 and 150. I would call it close to 200, maybe 190-ish. So the rate of an SVT is usually between 140 and 250. And so now let's look at our P waves. They're usually not discernible because the heart rate is so fast. Sometimes you can pick them up hidden in the T wave. So this peak right here is the T wave, which follows the QRS complex. And you can't really see a P wave in there because it's buried. Okay, the heart rate is so fast that you've lost your P wave. But we know that there is a P wave in there somewhere because the complex is narrow. Okay? So we can't really identify whether there's a 1-to-1 ratio here because we can't see the P wave. The QRS complex, as I mentioned, is normal. It's narrow. The ratio is not discernible, and the rhythm is regular. So again, the distance between each of these QRS complexes is the same, which means it's regular. So the SVT is regular. It's got narrow complexes, and the rate is between 140 and 250. Paroxysmal SVT is the same as SVT, but it sort of waxes and wanes. So you're going to go from a normal sinus rhythm into an SVT. So notice that the transition from normal sinus, which is here, to the SVT, the distance between those QRS complexes gets shorter. So here we still have a P wave, but at this point, our rate is so fast that we can't see that P wave. It's now buried in the T wave. Okay, so if you're struggling right now, pause this, have a look, go through all of your steps. Okay, if we look at the ECG strip from the beginning to about here, we'll see that it looks like normal sinus rhythm. There's a P wave for every QRS complex. The P wave looks normal. The PR interval is narrow. The QRS complex is narrow. The rhythm is regular. However, if we look at the entire strip, we see that something happens in the middle. Okay, this is called your paroxysmal SVT. You're going from normal sinus to an SVT. So the next one we're going to look at is the premature atrial complex, the PAC. So if we go through all of our steps, we're going to find that overall the rhythm is normal. The overall rhythm is normal sinus. When that happens, we call that the underlying rhythm or the underlying rate. So the underlying rate, if you go through all of your steps, you're going to find is normal sinus. However, we have this one random beat in here that's doing something a little funky. Okay, so go through all of your steps. Do we have a P wave for every QRS complex? Yes, we do. Is our P wave normal looking? Is it upright? Does it come before the QRS complex? Yes, they do. Is our PR interval narrow? Is it less than 0.2 seconds? Yes, they are. Is our QRS complex less than 0.12 seconds or less than 3 small boxes? Yes, they are. Everything is normal except for this one beat. So we look at this one beat. So it has a P wave. The QRS is narrow. Because the QRS is narrow and there's a P wave, we know it's an atrial contraction. We know that atria are causing the ventricles to contract because the QRS is narrow. So we're going to call this a premature atrial complex because we know the atria are causing the contraction because it's narrow. It just seems to have happened a little early. So if we were to take this entire complex and shift it over to the right a little bit, we would have returned to a normal sinus rhythm for the entire strip. So again, because this is narrow and because there's a P wave, we know that this is a premature atrial complex. Okay, everything else, the underlying rhythm is normal sinus. This one random beat is a premature atrial complex. Now again, if we look at this strip and go through your steps, you're going to find that the underlying rhythm is normal sinus, except for this funky beat right here. So the difference between the premature atrial complex and this premature ventricular complex is the size of the QRS complex. So you'll notice here that the QRS is wide. So the beginning of the QRS is measured from right here. This here is a T wave. So the end of the QRS complex is right here. So if you count your three little boxes, this QRS complex is wide. Anytime we have a wide QRS complex, we know that that electrical impulse has originated from the ventricles. So because this QRS complex is wide, again, it's originating in the ventricles, and for that reason, we're going to call this a premature ventricular complex. So the narrow one that we talked about earlier, that's a PAC, because it's narrow, it originates in the atria. This one is wide and originates in the ventricles. So this we're going to call a PVC. And again, everything else is normal except for this one beat. Okay, take your time, go through your steps here. So when we talk about PVCs, there are different types of them, different forms of them, and when they come in multiples or different rhythmicities, they have different titles, different names. So if we look up at the first one here, we have a number of PVCs, and they don't look the same. So we have a PVC here. We have another one right here. We have another one right here. Another one here. And they don't look the same. When there are PVCs on the same strip that don't look the same, we call them multiform PVCs. When we have a PVC that alternates with a regular beat, so here's a regular beat, here's a PVC. Here's a regular beat, a PVC. And that will continue on this strip. That's called a bigeminy. So every other beat is a PVC, therefore a bigeminy. If we look at the third one, every third beat is a PVC. Okay, so this is called a trigeminy. So this is your normal beat, PVC, normal beat, and so on. So every third beat is PVC, and that's considered a trigeminy. When you have two PVCs side by side, that's considered a couplet. Okay? And we'll get into how many it takes to consider this VTAC, which we'll talk about later. Okay? So take your time here, look at each of these strips, and go through each of the steps. Really, really go through each of the steps. It's very important that you do that. So the next rhythm we'll look at is the sinus arrest or sinus pause. So again, if you go through each of your steps, this underlying rhythm is considered normal sinus. However, there's a strip here where there are no beats. This strip is called our sinus pause or our sinus arrest, where nothing happens. For whatever reason, the heart just stopped working for a little bit, but then it started up again. Okay, so that's considered a sinus pause or a sinus arrest. And the duration of this pause can change. Okay, that can vary. So here's one that you might get a little confused about because it seems very similar to the sinus pause or sinus arrest. But this one's considered a sinus exit or sinus block. And in this case, when you look at the underlying rhythm, which again, in this case is normal sinus, you'll find that it appears as though one beat has been completely dropped. So if you were to throw in a complex here, everything else would be regular. Okay, so we're missing exactly one beat. If we look back at our sinus arrest or sinus pause, it doesn't seem so regular. So we could probably fit maybe 2.5 beats in here if we were to continue this regularity from the beginning. So this isn't as mathematical or as schematic as the sinus exit or sinus block. And I can, someone please remind me in our lecture, our class right before the midterm. I've got a quick little paper way of showing you if the rhythm is regular and if a beat has been dropped here. So someone please remind me of that and I'll show you how to do that. But again, the sinus exit and sinus block, it's obvious that only one beat here has been dropped. Everything else is normal. So the next set of rhythms we're going to talk about are junctional rhythms. And so junctional rhythms usually originate in the bundle of His area, which is why their rate is between 40 and 60. So think back to the conductivity chart that I showed you. The primary pacemaker up in the SA node is between 60 and 100 beats per minute. The secondary pacemaker, so the heart's plan B, sits in the bundle of His, and the heart rate is about 40 to 60. So if you think about the heart rate starting right in the middle of the atria and the ventricles, think about how that might mess up your P wave. So if you've got the electrical impulse starting right in the middle of the heart, that electrical impulse has the ability to travel upwards to the atria and downwards towards the ventricles. So because the electrical impulse originates above the ventricles, you're going to find a narrow QRS complex. Okay, so your QRS complex should be fairly normal. It should be narrow. Your P wave, however, is going to be a little different because that original impulse is not originating in the SA node where it should have come from. So in this case, we could have a P wave that looks normal, or it could be absent, or it could be upside down, or it could be after the QRS complex. So the P waves, what we're looking for is that it's absent, inverted, or retrograde. So absent, which means we don't see one at all. It's inverted, so an upside down P wave, which would mean that the electrical impulse is passing upwards through the atria from the bundle of His. Or the P wave is retrograde, so it's after the QRS complex, which would mean that the ventricles contracted first and then the atria contracted. And so if anyone needs a schematic or a diagram of this, just remind me on our review day and I can draw this out for you. Your PR interval can be normal, it can be short, or it can be completely absent. So if there is no P wave, then we can't measure a PR interval. Your QRS complex, as I mentioned, will be normal. It'll be narrow because the impulse is originating above the ventricles. And the rhythm should be regular. If you do have a P wave, the ratio of P waves to QRS complexes will be 1-to-1, again, if there is a P wave. So here's some examples of junctional rhythms. If we look at the first one here, there are no P waves. We don't see any P waves. So look at every single complex, go through your steps, there are no P waves. If we look at the second strip, our P waves are inverted. They're upside down, which means that that impulse that's originating between the atria and the ventricles, that impulse is going upwards, so it's going through the atria backwards, which is why this is showing up as an inverted P wave. And then if we look at the third strip here, you'll find the P wave is retrograde, so it comes after the QRS complex. Just means that the impulse that's generated between the atria and the ventricles has gone to the ventricles first, and then up to the atria. So again, here is your inverted P wave. Here is an absent P wave, because you don't see it. And here is your retrograde P wave. So think back to our PACs and our PVCs. So our premature atrial complexes were narrow and they had a P wave. Okay? They were just a random beat on an underlying normal rhythm. Our PVCs, our premature ventricular complexes, were wide QRS complexes found within a fairly normal underlying rhythm. Now we have a PJC, a premature junctional complex. So the premature junctional complex will be the same as the PAC, however, its P wave will not be normal. So the difference between your normal sinus rhythm and your junctional rhythm is that P wave. So the P wave here, in this case, looks a little inverted, right here. So the underlying rhythm is normal. This beat is early, so it's a premature complex. Now, what kind of complex is it? It's narrow, so it has to be either atrial or junctional. And I don't see a normal P wave, therefore it's junctional. So again, take your time, go back, have a look at this again if you're feeling at all lost. So we talked about our SVT already. It's our atrial tachycardia. You're probably not going to see a P wave because it's so fast. And now keep in mind again, as a reminder, the QRS complex is narrow, which means the impulses have originated in the atrium. Okay, above the bundle of His. Ventricular tachycardia is different. So ventricular tachycardia originates in the ventricles. How do we know that? Because the QRS complex is wide. It's wider than 3 little boxes, or wider than 0.12 seconds. Anytime an impulse originates in the ventricles, it is wide. So VTach requires PVCs, so each of these would be considered a PVC. However, a run of at least 4 of them is considered VTach. Okay, so if I only had 1 of these complexes, it would be a PVC. If I had 2 of them, it would be a bigeminy. But because we have 4 of these ventricular beats, we consider it VTach, ventricular tachycardia. Okay. The rhythm with VTach is regular. So again, if you look at the distance between each of the QRS complexes within the run of VTach, it's the same. So this is regular. Okay, I'm going to pause here and stop the recording, and we'll start up part 3 on this slide on the blocks.